Good morning, everyone, and welcome back to the second day of our virtual workshop on cancer care and cancer research in the context of the COVID-19 pandemic, Lessons Learned. For those of you just joining us today, my name is Richard Shilsky. I'm chair of the Workshop Planning Committee, professor emeritus at the University of Chicago, and the former executive vice president and chief medical officer at ASCO. This workshop is being conducted by the National Cancer Policy Forum, a convening body within the National Academies of Sciences, Engineering, and Medicine. Yesterday, we focused on exploring the immediate changes in cancer care delivery and cancer research during the COVID-19 pandemic, and concluded with a session on the opportunities and constraints of telemedicine in cancer care and research. Today, we'll convene 3 additional sessions, which will take a more forward-looking perspective, discussing the lessons learned to guide our next steps in the post-pandemic era to improve the delivery of high-quality cancer care and to advance the conduct of clinical cancer research. Participants will share their action-oriented recommendations to retain and build on the beneficial changes that have occurred, as well as discuss the policy, practice, and research challenges that will need to be overcome in order to spur progress on the delivery of high quality and equitable care and research. Before we start, a few reminders. Please use the chat box located below the workshop webcast to ask questions or make comments of the speakers and moderators. We ask that you please include your name and affiliation. I want to encourage all of you to ask questions, make comments. It really is your participation that drives this workshop forward. You're welcome to tweet about the workshop using the hashtag shown on the slide. After the workshop, proceedings will be published by the National Academies. Archived presentations and videos will also be available on the workshop website. So, without further ado, I'd like to hand it over now to our session 4 co-moderators, Drs. Randall Oyer and Robert Wynn, to introduce the first panel today.
Thank you, Rich. Welcome to today's first session focused on how the lessons learned from changes made during the pandemic can inform the delivery of high quality cancer care and explore opportunities to promote access to high quality, equitable cancer care in the post-pandemic era. I'm Randall Oyer, Medical Director of the Ann B. Barshinger Cancer Institute, University of Pennsylvania, Penn Medicine in Lancaster, Pennsylvania, and immediate past president of the Association of Community Cancer Centers. I'll be co-moderating this session with Dr. Robert Wynn, director of the Virginia Commonwealth University Massey Cancer Center. We have some very thoughtful speakers with us this morning. We'll begin with a keynote presentation by Dr. Lori Pierce, chair of the American Society of Clinical Oncology Board of Directors. Dr. Pierce is Vice Provost for Academic and Faculty Affairs and Professor of Radiation Oncology at the University of Michigan. We will then hear from Marcela Nunez-Smith, who is Senior Advisor to the White House COVID-19 Response Team, Chair of the Presidential COVID-19 Health Equity Task Force, and Associate Dean of Health Equity Research at Yale School of Medicine. Next, Shanta Chambers is Executive Vice President of Health Equity and Initiatives and Community Engagement of the Patient Advocate Foundation. Bhuvana Sagar is Chief Clinical Lead for Cigna's Value-Based Care Model in Oncology. Dr. Chris Lathan is Chief Clinical Access and Equity Officer at Dana-Farber Cancer Institute and Associate Medical Director at Dana-Farber Cancer Institute Network and Assistant Professor at Harvard Medical School. Dr. Karen Wingfield is Executive Director of the Meharry Vanderbilt Alliance and Chair of the Workforce Diversity Task Force at the American Society of Clinical Oncology. Dr. Loretta Christensen is Chief Medical Officer of the Navajo Area Indian Health Service and Acting Chief Medical Officer of the Indian Health Service. Just a few reminders, biographies of our speakers are available in the briefing book, which is posted on the workshop website. These presentations have been pre-recorded and will play consecutively. After the last presentation, we will begin a live panel discussion We encourage your involvement. We welcome your questions. Please use our chat box on the website to ask questions, and we are ready to start the presentations. Thank you.
Hi, I'm Dr. Lori Pierce, and I'm the chair of the board of the American Society of Clinical Oncology, and I'm happy to be with you today to talk about delivering cancer care more safely and equitably in a post-pandemic era. COVID has presented many new challenges to the healthcare system and to the population overall, but many of these issues with cancer care, many of them are not new. COVID exposed and exacerbated existing issues, and we've been working at ASCO to address many of these issues for years. At ASCO, we're hopeful that as we emerge from this challenging year and a half now, we can get to a place where we can further improve cancer care beyond what we were experiencing in the pre-pandemic timeframe, that we use this opportunity to learn, analyze, and permanently adopt strategies that can improve access to care and care delivery. And we can use this time not only to prepare us for the next public health emergency, which we know we will have to face, but also to improve the day-to-day interactions for our care teams and ultimately the experience and outcomes for our patients. The ASCO board convened a task force to explore research and care delivery changes with the pandemic and how they inform our road to recovery. And many of the task force's recommendations echoed policy changes that ASCO has long advocated. The pandemic was truly extraordinary, but much of its impact has been to highlight and intensify problems that we know already existed, such as access barriers, inefficiency of processes, administrative burden and inequities in care. And in some cases, such as with prior authorization, relief was promised during the pandemic, but it never happened. And in fact, the administrative burdens actually worsened for clinicians. So when you read the Road to Recovery report, you see that the recommendations are divided between clinical cancer research and cancer care delivery. And briefly, clinical cancer research, I know you've spoken a lot about that already, so I'll be very brief. It included the recommendations increasing patient access and equity by continuing remote and virtual approaches to consent and other trial procedures, and by better integrating trials into our routine cancer care processes. The report recommended increasing trial efficiencies by streamlining and standardizing regulatory and training requirements and using central IRBs when possible and using innovative trial designs. And also increasing flexibility among research teams and research locations so that treatment and research can be carried out closer to the patients. With regard to cancer care delivery, ASCO calls on policymakers, payers, clinicians, and others to build on strategies that help to meet the patient's most urgent needs during the worst of the pandemic. We need to be able to build on those things, specifically increasing access to care and equity of care by making expanded coverage for telemedicine permanent, preventing Medicaid cuts, ensuring accessible, affordable, and comprehensive insurance plans, and preventing other threats to patients' health coverage. Also, enhancing support for oncology practices in underserved communities and sustaining federal safety net programs. Also recommended policies for protecting patient safety. For example, creating new chemotherapy infection control standards for infection threats such as coronavirus, ensuring access to personal protective equipment and future COVID vaccines, and then limiting home infusion of potentially risky chemotherapy except at very exceptional circumstances. And we also advocated for supporting patient and provider well-being by expanding access to psychosocial support for patients and enhancing support for care teams. We know that there were pre-COVID disparities in screening based on factors such as race and ethnicity, factors such as income, education, healthcare coverage, and sexual orientation. And we've now seen how the pandemic dramatically decreased cancer screening rates. In this JAMA Oncology paper that used claims data from Medicare Advantage and commercial health plans, it showed quite nicely the dramatic decrease in screening particularly around the month of April, and then near complete recovery for breast cancer, but less recovery for colorectal cancer. We know the Affordable Care Act led to significant expansion of many aspects of care, including screening, vaccinations, and other preventive care. But we also know this coverage is not even for all Americans, and the results show poor survivals, especially for those among racial and ethnic groups, those with lower incomes, with lower education levels, as well as patients who live in rural communities. And so it will be important to continue to collect data from the pandemic to truly assess the impact of screening delays on populations overall, and particularly on marginalized populations. And when we talk about unevenness that some Americans face, we can again look at the ACA and Medicaid expansion. We know that there are still 12 states which have not expanded Medicaid coverage. And many of these states are exactly where there are disproportionate numbers of people of color, where these people live, where people of color reside. So when we discuss improving cancer care delivery and advancing equity beyond COVID, we see the urgency and need to fully extend Medicaid coverage for all. We must also continue to be creative in our thinking of cancer care models. And a perfect example is the Delaware Screening Initiative, which was an experiment that actually preceded the ACA. And in this experiment, clinicians, public health experts, and political leaders, they all joined forces to address disparities in care and outcomes in the state of Delaware for colorectal screening. And by underwriting screening and access to care for the uninsured, Delaware eliminated differences in colorectal screening by race and ethnicity and nearly eliminated mortality differences. And they ultimately saved money. And this experience can happen in more places than Delaware. And we at ASCO are working on ways to advance it now. So we can learn a lot from Delaware. Healthcare is a community enterprise. When we come together from many constituents, you can clearly improve the outcome for patients. And in this case, it was expanded access to screening and care was improved, and there was a lower cost to the system. So this is definitely a result worth repeating. And we must continue to call on policymakers to make expanded coverage for telemedicine permanent. I know that telemedicine has been discussed in this conference already, so I'll simply say that patient satisfaction has generally been quite strong, but there's more study that's needed to assess its optimal use as well as access and education challenges for our patients. And to that point, that more needs to be done to study telemedicine. ASCO has convened an expert panel, as I think you've heard about from Dr. Robin Zahn, and the key issues to be discussed are listed on this slide. So telemedicine standards and practice recommendations will come. Last year, ASCO published a policy statement looking back on 10 years of work and disparities and charting a path forward. And many of the problems we described more than a decade ago, unfortunately, persist today. So this statement acknowledged the disappointing statistics, but focused as well on real-world interventions. These are just a few of areas that we made recommendations. And since its publication, ASCO staff and volunteers have been working hard to implement these recommendations through a series of initiatives, including understanding how social determinants of health impact the ability to access high quality care, understanding what providers of the underserved need to deliver high quality care to their patients so ASCO can provide those resources, and along with ACCC, the Association of Community Cancer Centers, training to address unconscious biases and developing strategies to increase clinical trial participation among racial and ethnic minorities. Cancer outcomes could be dramatically improved if we consistently applied what we already know and scale the lessons that we've already learned. We know, for example, that organizational models that arrange service delivery closer to patients facilitate patient care. And while the healthcare system is certainly in need of both momentum and innovation in how care is managed, we need to be cautious in our approach. We do not want innovations to further marginalize disadvantaged populations. Similarly, we need to recognize that not all parts of the healthcare system are always included in these reforms. prevention and survivorship deserve just as much attention and care in our efforts. And then utilization management techniques and policies are a persistent burden to providers. None of these practices seem designed to protect or benefit our patients, and providers are constantly having to navigate these new hurdles, which often requires more administrative time, and it takes providers away from patient care. We recognize the rising cost of care and the challenges that we all face. However, things like step therapy and prior auth are not addressing this core challenge, and we strongly urge payers to reconsider their use. And finally, COVID further intensified burnout among cancer providers. We must acknowledge and address provider burnout and promote well-being in oncology. In May 2019, the ASCO Ethics Committee held a Burnout and Moral Distress in Oncology Roundtable. And from these discussions, a call to action and recommendations to address the issue were published in JCO Oncology Practice in March of 2020. And ASCO has since established the Oncology Clinician Wellbeing Task Force, whose mission aims to improve the quality, safety, and value of cancer care by enhancing the well-being of oncology clinicians and sustainability of practices. This task force has developed a roadmap for broadening resources in this arena, and I sincerely hope that members of this audience will check this site frequently as additional resources are constantly being added. Thank you so much for your attention.
Hello, everyone. Thank you so much to the National Cancer Policy Forum for inviting me to be with you today. I'm Dr. Marcela Nunes-Smith. I'm Senior Advisor to the White House COVID-19 Response Team and Chair of the Presidential COVID-19 Health Equity Task Force. I'm also the Founding Director of the Yale Equity Research and Innovation Center and Associate Dean of Health Equity Research at the Yale School of Medicine. Relevant to today's conversation, I'm the Chief Health Equity Officer at our Smilow Cancer Hospital and Associate Director for Community Outreach and Engagement at our NCI designated Comprehensive Cancer Center. It's great to be with you, but the occasion is certainly a somber one. This past year has been more challenging than any of us could have predicted. But importantly, it has brought to light some fundamental structural problems, and now those have been catapulted into our public consciousness. The conversations happening now, they are long overdue, but importantly meant to address historical and contemporary patterns of inequity. And these patterns permeate our whole society. This particular session provides a vital space to center equity in conversations concerning the impact of COVID-19 on cancer care and cancer research. So with the understanding that this past year has been both incredibly challenging and also illuminating, I'd like to talk about some of the steps we can take to address patterns of inequity in healthcare and beyond. And the most fundamental concept, our starting point, has to be deep engagement with communities, and that is at every step of the way. Communities are expert in what they need to thrive. I am deeply honored to have a seat at the table in the Biden-Harris administration's response to COVID-19, advising on response and recovery strategies that acknowledge the centrality of community. And in advancing health equity, we need to acknowledge the presence of structural racism in our medical institutions and really live into the practice of anti-racism moving forward. When we talk now of the history of racism in American medicine, the US Public Health Service's study of untreated syphilis in the Negro male at Tuskegee, Henrietta Lacks, the gynecological experiments of James Marion Sims, that's important and important to have in our collective understanding. But as important, if not more so, is we have to keep in mind that for many, many people, institutionalized racism, that's a contemporary, everyday reality when they seek medical care. And so to that end, we need to elevate patient voice. We have to capture the patient experience as related to equity. As we focus on quality of care, we must approach this equity dimension with the requisite scientific rigor and scholarship. Certainly, we also have to ensure diversity, representation, and anti-racism in our health professional schools, across our curricula, and in health professional organizations as well. So to step back and talk about quality again, that 10 to 20% of variation in outcomes that are attributable to differential healthcare quality, it's not acceptable. Yet, we know that it is 10 to 20%. So much of what drives health, the rest of that pie, is the result of social and structural realities. A long history of racialized and targeted policies and practices in our country, in housing, nutrition, education, policing, immigration, employment. They function to marginalize too many, and in doing so, systematically limiting access to resource and opportunity. And for those of us who are involved in the research enterprise, we cannot take or find professional satisfaction in describing patterns of inequity and injustice. We must reorient. Our commitment has to be there to intervene, to drive transformative change. Look, we need better data. Our current data, our data systems simply do not accommodate what is the socio-demographic complexity that's experienced across communities and vital for our understandings and our interventions. On that same data front, we have to insist on the complete disaggregated and intersectional data that are necessary for a data-driven approach that will enable health systems, organizations, and communities to advance together towards health equity. When I think about the pandemic, really importantly, the demographic data collection has improved substantially. Yet it remains incomplete. Missingness is not random. Not only as we talk about communities of color, but the lens is broad. We have to consider all medically underserved communities, rural communities, those who are undocumented, mixed status families, people experiencing houselessness, those who are incarcerated or justice involved, gender and sexually diverse people, disabled individuals. We do not know the full extent to which these communities are suffering in the pandemic. And for most of our healthcare delivery systems and networks, we cannot speak to their experiences in our data. I talk often of partnership and collaboration. Working towards health equity, this is not a task only for medical professionals or only for researchers. Knowing that biological health profoundly shaped by dimensions outside of the construct of medicine, we have to be intentional about those partnerships that we create across domains, across sectors. We have to think, obviously, about healthcare, about medicine, but also about the environment, environmental justice. Think about economic reform, developing policies and practices that integrate health and well-being into the fabric of everyday life, a recognition that health should be prioritized in all policies. We know when it comes to health inequities, a person's zip code is a stronger predictor of health than their genetic code. In the clinical care arena, we need to be proactive. We have to anticipate needs that will arise as our health system adapts to needs brought about by the pandemic and eventually to a post-pandemic environment. Let's consider telemedicine. The potential there to increase access to care. It lowers the burden of transportation, childcare, some of the most pressing structural determinants. But, we know that it can also exacerbate health problems. For those patients who have limited digital literacy, who lack access to technology, who don't have reliable internet or broadband, the work is underway, understanding better about telehealth during the pandemic. But there's studies that have already shown patients with limited English proficiency less likely to utilize telehealth services. We, of course, know the impact of payment on the type of phone and ability to connect on video that we've seen. These are examples that make it clear that telehealth, without an intentional focus on equity, can create cascading effects worsening the health and access of patients who are already medically underserved. When we bring into sharp relief COVID's effects on cancer, we have to anticipate those inequities that are rising from care delays. We can articulate the gaps in our knowledge about COVID, equity, cancer. We cannot abdicate our responsibility to center equity, though, in every step of this process, knowing communities have differential levels of availability, accessibility, and quality, right, in terms of healthcare services. Before the COVID-19 pandemic, we already knew and saw documented patterns of inequity in cancer diagnoses and across the entire cancer care continuum, where we see race, ethnicities tracking so strongly. For each of the most common types of cancer, racial ethnic disparities persist, despite the progress we've made overall in reducing cancer deaths. So we can't really confront these disparities without also confronting the embeddedness of disparities in our social fabric, the spatial patterns of disinvestment and discrimination. This is the legacy of those. People of color less likely to receive guideline appropriate surgery, other therapies, less likely to be enrolled in clinical trials. Let me just say, equitable access to participation in clinical trials, to the promise of scientific discovery, that is critical. We also need to prioritize representation in our workforce and in our healthcare leadership. All of this has become just more urgent when we think about COVID-19, compounded by these delays in screening and cancer care. It's a whole set of new crises for minoritized and marginalized groups. We think too that people of color, others, with the greatest cancer disparities, are most likely to be essential workers as well, to have jobs that are at risk, even lost during the pandemic, and therefore the loss of health insurance as well. And as we previously discussed, limited access to technology and to telehealth services. We know the challenge of inequity reflects longstanding, deeply rooted systemic realities, COVID-19, cancer, all of these dynamics interweaving. So not suggesting that these problems are easily solved, but we must build resilience into our recovery. Imperative we engage with communities from an asset-based frame rather than continued over-reliance on deficit models. As we consider just the vastness of the pandemic response and recovery, the Biden-Harris administration is committed to a multi-pronged strategy that is equitable. And I remain optimistic, precisely because of gatherings such as this. And so I thank the National Cancer Policy Forum for bringing together clinicians, researchers, advocates, policymakers, and others in service of finding an equitable path forward and finding that path together. Thank you so much for the opportunity to join you today. Everyone, please be well.
Good afternoon. I'm Shanta Chambers, Executive Vice President, Health Equity and Community Engagement, Patient Advocate Foundation. Next slide. For weeks, we saw article after article about the coronavirus, the impact of the coronavirus on specific populations of people, specifically African Americans, and within economically impoverished communities. But this is still a story half told. Missing from the initial headlines was the broader narrative of the impact of unaddressed social determinants of health and the enormous social need gaps caused by them. COVID exposed the consequence of unaddressed social needs in a way that impacts access to care and treatment adherence. The social, environmental, economic, and cultural determinants of health are the terrain by which structural inequities produce health inequities. These multiple determinants are the conditions in which people live, including access to good food and water and housing, the quality of schools and workplaces and neighborhoods, and the composition of social networks and the nature of social relationships. Yes, it negatively impacted healthcare delivery within the global community and was extremely destructive within inner cities. However, again, that's still a story half told. Next slide. Historically, healthcare and the social determinants of health have existed as two isolated, independent phenomena without much acknowledgement of how interrelated the two are and how critical social determinants of health are to healthcare access, quality, adherence, healthcare related outcome, and also cancer survivorship. Next slide. So when I think about our path forward, I draw to this quote from Dr. Kamara Jones that says, you know, we can do a really good job of reducing health disparities and better connect people to high quality care. But if we really want to have the sustained impact, we must address the social determinants of health and equity that protect some people while pushing others off the cliff. Recent data attributes 10 to 20% of healthcare outcome to medical care, 30% to genetics, 40 to 50% to behavior, and 20% to the social and physical environment, i.e., social determinants of health. So when we think about it, the social determinants of health in some instances are more impactful on one's disease outcome, quality of life, and ability to adhere to care than the actual delivery of medical care alone. Calling out again the important nature, the important opportunity, and the important impact of the social determinants of health. Next slide. This slide actually presents to you some key findings from a project that Patient Advocate Foundation launched last year in response to the pandemic. And it was addressing food insecurity in partnership with Team Rubicon with the generous support from the Brisker Myers Squibb Foundation. I bring this out because I want to highlight the importance of food insecurity and, more importantly, the impact of food insecurity on overall health and wellness. We have to keep in mind that our collective health and well-being depends on aspects of our lives beyond the healthcare system. So as I've already pointed out, medical care is important, it's significant, but so are these social determinants of health or the social needs that are actually caused by them. And so when you look here at this slide, what you see is the first question was asking individuals if they were having trouble gaining access to very basic things like water and food. And then the second chart asked them, were they having trouble paying for it? So if you draw your attention to the bottom line, 68% of these respondents who are individuals living with cancer, multiple sclerosis, or rheumatoid arthritis acknowledged that they were having trouble paying for food. And when you look at this list of things, food was the one thing that they noted that they were having the greatest challenge paying for. And we know that we often say that food is medicine, but food, yes, it is medicine. In this case, it was the greatest barrier for many individuals who completed this survey. Next slide. So how do we begin to think about things differently? So there is a role that the healthcare system can play in actually addressing food insecurity. This is a great example from Feeding America that provides how you can actually assess for and actually triage those individuals who identified food insecurity to resources. This is a great opportunity for us to augment the way that we engage with our patients by going beyond just what's most important in terms of their health care or their medical care, but also taking a moment to understand the food insecurity gaps or other social need gaps that may be at play that may hinder their ability to be able to adhere to any degree of treatment recommendations that we may be setting forward. Next slide. So our path forward. Our path forward is one that brings together healthcare delivery and social determinants of health. Well, we create a systemic approach to how we actually assess for social need gaps, but more importantly, create a triage system by which we connect those individuals with identified social needs to local, community, or national resources. That does not mean that we have to build an entire infrastructure to do it. What it means is that we have to be intentional around augmenting our intake processes or various points within the care delivery continuum to ask about these questions, to ask about these other factors that may be non-medical in scope, but are critical to our patients being able to access and adhere to any treatment recommendation. This is where healthcare and social determinants of health come together, and collectively we can respond to identified social need gaps. Thank you.
Hello, good morning. Thank you very much for inviting me to be a part of this discussion. As you all know, I represent Cigna, and we payers also play a critical role in improving the quality of the healthcare ecosystem in partnership with providers, clients, and also patients who are our customers. Overall, we have been, last year was an incredible year due to COVID, with significant decreases in utilization that we saw across the board in the months of March to May. We saw that this impacted several services, but also impacted cancer screenings for multiple different cancer types. As you can see on the graph, the significant dip in April and May, but these numbers rebounded over time. So as I mentioned earlier, we track utilization numbers across the board, and our clinical teams typically follow this, gains insights, and also send out notifications or reminders to patients to make sure that they are getting their screenings done. We mailed out several kits, even for the fit kits for colon cancer screening instead of colonoscopies. Overall, we also sent out a lot of resources on tobacco cessation programs. This year, we're focusing on breast cancer screening initiatives and also colonoscopy reminders. Going on to the next slide, this actually shows the information on the dip in new starts in therapy that we saw last May. These have significantly recovered back to baseline. We anticipate continued increase this year as well. We saw that some surgeries, medical oncology chemotherapies also rebounded earlier part of this year. We intend to continue to monitor this. We did not see any significant increase in advanced stage cancer so far, but we are monitoring that data as well. Going on to the next slide, this talks about the virtual care experience in oncology. So the two graphs here, the blue is the behavioral utilization, and the orange is the oncology care utilization. As you can see, even prior to COVID, we saw there was a supply and demand issue between providers and the need for care. And what we saw during COVID was the need for behavioral health exploded dramatically. We as payers saw this, took advantage of this. We made sure that people have access to their benefits, and also expanded our network even prior to COVID to incorporate several virtual providers. We also, during COVID, expanded it to include non-traditional providers as well, and also made access to digital health as well. So about 2/3 of all behavioral visits happened virtually, and we anticipate that this will continue going forward to a large extent. Oncology, as you can tell, the virtual visits spiked during the month of May, April and May, and it has actually leveled off. And we know that for oncology, not all visits can or should be virtual. We need to continue to evolve and build effective models to determine who would be appropriate for virtual care going forward. So as payers, we also did a lot of coverage updates, making sure that patients had access to therapies where they could extend the intervals between therapies. A great example was a lot of the immune checkpoint inhibitors, expanding it from every 2 weeks to every 4 weeks, or every 3 weeks to every 6 weeks. So we worked very closely with NCCN and also ASCO to make sure that those coverage policies were updated as well. We made updates to our alternate payment models where providers were not dinged for increased utilization that happened as a result of COVID. So when patients got admitted to the hospital because of COVID, those admissions were actually excluded. Those patients were actually excluded from the analysis. Going on to the next slide. This is a great example of some of the clinical policies that we as payers put in place to incorporate testing as part of therapy. I know there have been a lot of concerns that not all patients are getting access to the right testing prior to their therapy choices. So we saw our baseline data prior to 2019. There was only 62% adherence on molecular testing prior to starting therapy for advanced stage non-small cell lung cancer. We put a program in place to ensure that we're asking the provider at the time of prior authorization if they've had these tests done, and looking for the test results, for example, of EGFR and ALK mutations prior to approving immuno-oncology therapies. And we were able to nicely show a nice increase to over 97% utilization. And as you all know, this is critical because we need to identify patients who have these mutations and make sure that they're getting on targeted therapy in those settings. We also did a similar program in breast cancer for early stage breast cancer, making sure that they're getting Oncotype, for example, to see if they would benefit from receiving additional adjuvant in the chemotherapy in the adjuvant setting. Going on to the next slide. So looking forward, because I was asked to make some comments on how are we thinking about this going forward. And this is a great question. So in July 2020, we launched a Building Equity and Equality program. Overall, as an organization, we realized that this is a key space for us to be in, and we need to motivate our providers to also incorporate all these things as part of their workflow. We all know that 80% of an individual's health is determined by their health behaviors and also by the environment in which we all work, live, and play. So our 2021 strategic goals center on expanding and accelerating health equity. So what we've done is our benefits team is working on opportunities for improving plan design overall, enhancing and expanding coverage, accessibility, and affordability of virtual visits to improve access of care to all our customers. We're working very closely with our large provider groups across the country on health equity issues and also social determinants of health value-based reimbursement initiatives as well. So there's a lot of work ongoing in this space, and we're really excited to be able to work on this, to be able to close gaps in care as a result of that. In 2021, we have actually launched some additional rewards initiatives to reimburse providers who are screening customers for social determinants of health, and then also doing the appropriate referrals to address their needs as a result of that screening. So we truly are also working with our oncology care partners as well to understand where they are in the journey in understanding health disparities among their patient population, and also trying to work with them closely to improve on that together with us. So in conclusion, there's a lot of work ahead for all of us. We need to continue to be a force for positive change. Our goal is to contribute meaningfully to create that type of diverse, equitable, and inclusive culture that is going to enrich all of us in general. Thank you very much for the discussion today.
Hello, this is Dr. Christopher Lathan. I am the Chief Clinical Access and Equity Officer at the Dana-Farber Cancer Institute in Boston. And I am a medical oncologist who focuses on taking care of lung cancer patients. And my research has been focused on thinking about care delivery and care redesign for underserved patient populations. I'm going to talk to you today about some opportunities for care redesign, specifically for vulnerable communities. In light of what we've learned from our experience in COVID, we know that the cancer center and the medical infrastructure in general is more adaptable than we thought. And I think there's some opportunities for us to really think about how we can change that to focus or utilize that to focus on our underserved communities. So what I'd like to do is talk a little bit about briefly some issues with precision medicine. You've heard from other speakers today about some of the major gaps that we have regarding racial disparities in cancer care. And then I want to talk about specifically the role of the academic cancer centers and what they do, and think about some interventions that we could do and some unique opportunities. So first of all, just talking a little bit about access to care. We know that cancer diagnosis and treatment is very complex. It's hard for folks to get diagnosed and to move from a symptom to diagnosis, or even a screening abnormality to diagnosis. And for working poor people in general, this is a struggle. I think thinking of this as an iterative process really helps you think about how people can get lost in the struggle. And if you're working an hourly job, taking time off to go for multiple appointments is very difficult. And then beyond the clinical questions and issues that you have with diagnosis, the other issues tend to be that there are insurance problems, there are other barriers that really get in the way, sometimes financial, of delivery of services. And that means that the folks with the most disease burden tend to have the most restricted plans and the need for services and the least amount of resources. And then something that we've seen for cancer centers, throughout the country is that they're not perceived the way that you would think that they would be by the communities in the more vulnerable communities around them. So if you move to suburbs of almost any cancer center, then the cancer center is seen as a destination place to get a second opinion and think about clinical trials. But for working poor communities of all races, but specifically thinking about our BIPOC communities, there is not necessarily that same feeling about the cancer center for lots of reasons. But the cancer center seems to think, oh, the doors are open, people will utilize us. But it doesn't work that way. You really have to have a consistent clinical navigation program and a sustained clinical presence in communities, which necessarily it really hasn't been there. And so we know that the cancer care access matters. We know that we really want inclusive, high quality care for our underserved patient populations. And the feeling is if you really do that well, if you take care of underserved patient populations, then you will have the infrastructure for excellent care and clinical trial access for your other high-end patients as well. So this is not something I think that building this infrastructure, I think, will benefit the whole population, but focusing on your underserved patient population is extremely important. So here, I want to just touch for a minute about the lung cancer molecular testing precision medicine issue. And briefly, just to say that at the start of our, when I started my training in lung cancer back in 2001, 2002, there was really just chemotherapy for lung cancer. And certainly, it's been amazing to watch our therapeutic options change, linked specifically to knowing what the driver mutations are and being able to identify that and link patients to specific treatments, precision medicine. Well, what we know now, right, and we know that early on that specifically African-American folks were left out of some of those initial studies. And the initial clinical thought was that African-American patients and white patients in the US had different mutational patterns and people weren't looking for them. And this was wrong. And we published a paper that showed that it was wrong and that the mutation patterns were very similar between whites and blacks in the US. And the current state in non-small cell lung cancer in adeno subgroup is the recommendation is there should be at least, but in 2019, there should have been at least 4 major tests, 4 major sequencing or somatic mutations that people were looking for, as well as an immunotherapy marker. And there was some data presented at ASCO really just this year that showed that only less than half of the people who were surveyed in both the Flatiron data and also a large oncology, private practice oncology group data showed that probably about less than half of the people are getting what we call next generation sequencing, which is the total list. But not only that, but probably the similar amount we're not having all 5, the 4 somatic mutations plus the immunotherapy tested for. And Black patients were less likely to have comprehensive testing. And those who are tested were more likely to be in clinical trials by almost double the amount. So with the new drugs coming out, this is really important for us to figure out what the problem is there. I think the cancer center, and if you think about what the cancer centers have been trying to do, really grow their networks and think about delivering care closer to the point of where the patients are, that's fantastic. But the truth is, I don't think that's really happening the way that the cancer centers wanted to. And part of that is the inadequate support network, whether that's your CRCs or your research nurses, your overall providers. I think there's a difference between those who are single disease subspecialists like myself and the folks who are working in the communities who are dealing with benign hematology as well as all the other cancers. The type of trials that they want is different. And so when we're thinking about what we're bringing to the community, a lot of times that's not in alignment. And also there's this conversation about payer mix. So the idea is you're expanding your satellites, you want to bring in more patients, but the business side is also thinking about the margin. And sometimes the very patients who have the most vulnerability are the ones that they're worried about, well, we're going to get reimbursed not enough, and we're going to have problems, we're not going to be in the black. And that's important too, because you want your clinical enterprise to support your research enterprise. So I think this conversation needs to be more integrated throughout our cancer centers so that you can expand and take care of your underserved patient populations. And if there are other areas where the Institute has more generous opportunities, then you could take that and spread that along your infrastructure, your clinical infrastructure. I think community engagement is the most important part here, and developing relationships within the community. It has to be not just based on what the cancer center needs. If you establish a trust, you have to give back to the community and you have to be durable and present. And I think one of the problems with our interventions is that we don't necessarily do that. I think that if you really think about how to move forward and how to make changes, you have to broaden your partnerships with community centers, federally qualified health centers into your community and your community liaisons. You got to create your interventions, measure your impact. You have to really think about community-facing or focused navigation and internal navigation, thinking about how these things could work. And we have a program that's called Cancer Care Equity Program where we do some of this work. And then I think as far as your precision medicine and moving forward, you really want to think about really true transdisciplinary research. And that's how you're really going to fix this precision medicine issue as well. I think then, think also too about synergies with dentists, oral health, HPV, head and neck. Think outside the box for where you want to go. And if you really want to move forward and think about priorities and timeline, building your community engagement navigation process is really important. And I've listed some areas here, engaging with faith-based groups, thinking about your catchment area, and really talk about bidirectionality. And then really thinking about what are your existing strengths, whether it's your network sites, what have you, and how are you going to utilize that to focus on health equity and disparities. And lastly, I just want to finish up with some thoughts that we had from an NCI session where there's a conversation between the cancer centers and NCI. And really, this has been published, but just thinking about NCI has been focused on measurable impact. We want to think about community outreach beyond education, and the academic medical centers really have to think about this work and think about different ways to promote folks who are thinking about how we increase health equity and how we think about our interventions. So thank you very much for your time.
Hello and welcome. Thank you so much. My name is Dr. Karen Wingfield, and I'm so ecstatic to be on this panel with a lot of my colleagues that you've already heard from about the issues related to equity and access. And I'm a radiation oncologist, so I'm going to talk about access to radiation therapy. So I want to thank the organizers for inviting me. Here are my disclosures. So one of the challenges when we think about access is that socioeconomic status is really the greatest predictor of health. And so a lot of times my colleagues, radiation oncologists, were like, well, what is it that we need to do in this space? How can we really impact the social context that people find themselves in, right? We can't really do much about their income, occupation, or education. But it's really important for us as providers, as researchers, to understand how crucial this matter is, this issue of socioeconomic status. When you think about the fact that children living in poverty are 7 times more likely to have poor health, how then do we incorporate that concept in terms of how we think about access to care, access to radiation? If you haven't seen this documentary on natural causes, I would encourage you to take a look at it. You can find it on YouTube, but it actually outlines the fact that wealth equals health. It's a predicator. And so it's a huge predictor that we need to be cognizant of. If you think about these maps, many of you have seen them before, where they kind of plot along distances, the lifespan of individuals. And this one is reflective of North Carolina, where individuals who are living closer to the city have a lifespan of 80 years, and they die at age 80 as an average. The further out you get into rural communities, the age actually goes down. People are starting to die sooner. There's a 7-year difference. And we see the same thing when you're living in urban areas. This is actually looking at New York City and the gaps in health based on where people live. We can actually look at our nation's capital. If you go along the metro stations, and the fact that place matters so much in health and access to care. Many of you already know, those of us who are on the front lines, those of us who treat patients know that transportation is really the #1 barrier to accessing healthcare, and that includes radiation. So what happens when you have radiation therapy that's every day, but it's a critical component of your cancer care? Well, these are the issues that we face. And I tell you, COVID has really highlighted some of those issues. For some, it's the first time that the issues related to access to care, the issues related to equity in cancer, or equity in healthcare in general, are even coming to the forefront. And so my colleagues and I wrote this paper that was published in the Red Journal, so the International Journal for Radiation Oncology, Biology, and Physics, that really highlighted some of the lessons from COVID-19. What are some of the things that we can learn from the pandemic that will help us to address the issues related to health equity? And that includes transportation. I'm just going to highlight a few of those here because I really hope you'll read the paper. I try not to give away all of the goodies because I really do want people to go and look at the paper themselves. one of the big questions we ask is, how can radiation oncologists, and we can take out radiation, we can just say, how can oncologists, how can providers be engaged in bringing more equitable cancer care to the communities we serve? Well, the first thing that we list is really thinking about having more research and advocacy related to health equity. So this is research about health equity. And I'm not talking about these descriptive studies that oftentimes you'll see, large databases. We need to stop describing the problem. We know the problem exists. But how can we be innovative in the way that we actually design clinical trials so that they are asking the appropriate questions to think about health equity? Are we actually including social determinants of health into some of the data that we're capturing? If we're collecting patient-reported outcomes related to radiation or oncology care, are we asking people the questions that they value? The only way to really do that is actually to engage them in the process. And so that's one of the critical things that we're learning through COVID, that we've seen through COVID. It's not enough just to do outreach, right? The public outreach is still resulting in the fact that we don't have everyone vaccinated, right? But we have to be inclusive. We have to do the engagement work. And that includes those of us who are frontline radiation. We have seen that, we've been able to change the way radiation therapy is delivered. We've shortened the treatment courses, which certainly makes access easier. But we still need to study what the results of that is. What is the result of shortening treatment, times? How does that impact patients' lives? Is it making it easier for them to actually get the radiation therapy? What about the side effects of treatment? Are we capturing that? These are the sorts of equity questions that we need to ask. But we also need to start thinking about policy implications, and not just, at the national level, because look, I'm all about understanding federal policy. But what are the policy implications for departments? We know that unfortunately, funding is tied to the length of treatment courses. And so these are the sorts of things that we as radiation oncologists, can really start to think about. How can we actually improve access by using policy to think about how reimbursements are made for the departments, for the institutions? And how can we ensure that patients are not kind of having undue burden related to their cancer care? These are the sorts of policy things that we need to think about. We also outlined the importance of direct collaboration with communities and community engaged researchers. So again, the importance of having the patient at the forefront, their families, individuals impacted by cancer. But we need to do that with the thought of having research questions in mind. And this is where having folks who understand the methodology can really help us as radiation oncologists to do that and do it well. And I could not do this talk without talking about the importance of workforce diversity. We know that it's really vital that patients see people who look like them. We've had studies that have shown that patients feel better when they have people who look like them. But this slide from one of my colleagues really shows that we have a lot of work to do with respect to some of the racial and ethnic gaps that we see, not only in terms of the outcomes that some of my colleagues have already talked about, but also specifically related to workforce diversity. We see there's not been much change, that flat line that we see in terms of who the US faculty are in representation for radiation oncologists or even Black physicians in general has remained pretty stagnant at about 3%. So we've got some work to do. And why? I hate to talk about the business model, but unfortunately that's where some folks have to hear it. Diversity is good for business. Diversity and inclusion is good for business. And really it's that diversity of thought that leads to innovation. It's what will help to drive some of the changes that are going to be required so that we have sustainable equity post-COVID-19. My colleagues and I also really wanted to share why racial justice matters, because I tell you, I've done some of these talks and some people aren't so happy when we have these conversations. It's a real conversation we need to have in the United States. Again, I encourage you to take a look at this article that was published in Advances in Radiation Oncology and really outline some key things that individuals and institutions can do to really improve equity. This here, acknowledgement, so the ATIP principles, really thinking about ways that we can acknowledge the past but be intentional about changing the future are really important. Talked about the importance of representation as well. And finally, the LEADS approach to reducing anti-Black racism and radiation oncology. It's really important for individuals to do the work. Each of us must take time to understand the problems that have led to Black racism in the United States. But then what are the things that we can do to help ameliorate and alleviate those problems? Because frankly, the better we are at improving workforce diversity, the better the access is going to be to the patients who so desperately need it. So thank you so much, and I look forward to the future discussions.
Hello, I'm Dr. Loretta Christensen, and I'm very honored to be with you here today. I am a CMO with the Indian Health Service, and I'm a proud member of the Navajo Nation. Just a brief overview of the Indian Health Service. We provide comprehensive care to about 2.5 million American Indians and Alaska Natives, and we serve over 574 federally recognized tribes. Working with a budget of about $6 billion, we have the staff as listed below on the slide to take care of our patients across the nation. Our system is set up into hospitals, health centers, Alaska village clinics, health stations, school programs, and some youth treatment centers. This becomes very important when we look at how we serve the rural areas of the United States and how far-reaching this rurality is. We try to strategically place our facilities to allow access for the majority of our population. Just some brief COVID data, what we've faced over the last 16 months or so. We've tested over 2.5 million people with 202,000 positive cases. Our current rolling positive average for 7 days is 6.4%. And we're very proud that we have given 1.46 million doses of vaccine. So I want to talk just briefly about the social determinants of health, which existed pre-COVID and will exist post-COVID, and things that we tackle all the time in our communities. We have multi-generational homes, which are generally a very good thing because our elders are in our homes and there's historical knowledge passed on. But during COVID, of course, this was very detrimental as people could not socially distance. And often we were treating families that were positive, not just positive patients. There is still a lack of running water and utilities in a great deal of our communities across IHS. This also created issues with hand hygiene and sterilizing and cleaning one's home and utensils, etc. The lack of transportation, I match that with lack of roads because not only are there difficulties getting where we need to go, there aren't really very good roads, and some of them are still dirt in many of our places, which means in inclement weather, it is almost impossible to get back to a main road. This will create a problem when trying to get to appointments, specifically those that we refer out of town. We also have a significant food insecurity problem, and that there are very few grocery stores in many of our IHS areas. You have to drive an hour or more sometimes just to get basic food. This was also a problem in the pandemic, is because you want healing and good foods accessible for people that are ill. And it was very difficult. We used a lot of food distribution during the pandemic. Poverty, of course, is a given. And when I say access to education, I'm also referring to the education involved with any disease process, as well as an overall lack of opportunities for education. Additional challenges across IHS, there is a significant lack of broadband. We have poor cell service, it's spotty or non-existent. So when you're looking at telehealth and telephonic type of consultations, it can be very challenging. Our access to specialists is very limited, as no specialist really can set up in many of our areas, as there wouldn't be a volume to support their practice. So therefore, it becomes very difficult when we are looking at cancer care and things like that, your orthopedic care and specialties that we need to go to an urban area. Culturally appropriate care becomes a very big issue for us because cancer is very overwhelming, as we all know, and trying to explain it in that native language within the context of that culture becomes very challenging. Just understand how difficult it is to send someone to a cancer center when they don't speak English very well. Cancer is very scary to them, and we're trying to put it into terms that they understand what they're fighting and how we are going to provide treatment to them. So that has been very, very difficult for many of our tribal members. Trust, I'm referring most to historical trauma, which we all acknowledge. We spent a great deal of time during COVID trying to heal that so that we could proceed with the vaccines. And I think by the numbers you see, we did a really excellent job, very much depending on the family community commitment that our tribal members have to get vaccinated to protect their people. And then lastly, we still deal with some environmental issues. For example, in Navajo area, we have uranium toxicity, which there are multiple unmitigated mines that are still exposing people to the toxins from uranium and the heavy metals. So that adds a challenge to what we're doing as well. I want to take a moment, though, to frame this in a positive way as some possibilities that we can move forward. We definitely want to increase the use of telehealth for cancer care access and work with our partners at the cancer centers. If a lot of this can be done through telehealth, our people can stay home close to family. We have some examples of satellite clinics for cancer care that are supported by our larger cancer centers. Great examples of that allows some radiotherapy and chemo to be done very close to home, which is wonderful. We have some collaborative agreements, but we'd like to increase those to support access to cancer center consultation and case reviews. We want to invest in cultural appropriate education for tribal members that will help us set the stage of what may come forth if they are diagnosed with cancer. And then one thing I really want to bring out is support for community-based cancer screening. We have excellent programs which are going out in the communities to screen for cancer and hopefully diagnose those much earlier because we're seeing it in the late stages. So those are some great possibilities moving forward that I feel will be very positive for our Indian Health Service patients. I'm showing you a beautiful picture of where I come from, and it is just, we walk in beauty here, but I want to also point out to you how rural this is. And these are the people we are trying to get to care. So hopefully we can work together and find ways to create more equity and access to cancer care. Thank you so much for this opportunity to share my thoughts with you.
That was fantastic. And I also want to say special thanks to Dr. Nunez-Smith, who will not be able to join us with the live panel, but has actually directly texted and put in the chat and an email that she's really looking forward to the outcomes of this workshop so that we can proceed with the work forward. I think we'll get started with Randy and I, and I'm going to throw out the first question. What cancer treatment adaptations or innovations in healthcare delivery should we move forward or should we carry forward? And I'll open up to any of the panelists, if any.
Well, if everybody's going to
go ahead.
No,
okay, this is Ivana. So from a payer perspective, we are seeing a lot of utilization of virtual care, especially I think from a behavioral health perspective. We also need to keep in mind that anytime somebody's diagnosed with cancer, it is a very stressful situation for them. They have a lot of anxiety, and we are seeing increased utilization of behavioral health across the board, and we're seeing that utilization staying up fairly consistent at this point. Now, for oncology care itself, obviously not everything can be delivered virtually. So there's some things, maybe medication management or chemotherapy education and those type of things can be done virtually. We're seeing some utilization of virtually across the board. So I'm going to pass it on to Chris. Go ahead, Chris.
Well, I was just going to say that, what has been studied, extensively, right, in the cancer realm is navigation. And the integration of navigation, I think, in a more prospective way and related specifically to and linked to our outreach and education program. So I think that is something that there's a lot of data on and that we can really integrate in very innovative ways to make sure that we can expand things for our community. So I think that's a low-hanging fruit. There's other things we can do, definitely, but I think that's one area where I don't think we've really taken the baton on that and ran with that as much as we should have.
Yeah, and I was going to say, on similar lines, I do think the digital health piece and being able to do telehealth is really, really critical. It allows for patients, for instance, from a radiation perspective, for their initial follow-up perhaps to be done at home and they don't have to drive in 400 miles. But we need to keep in mind what Dr. Christensen said in terms of access, right? That digital divide, which is really important. And that's where actually navigation can help. And I love the fact, Dr. Lathan, that you brought up navigation, because I believe not just in nurse navigation, but in lay navigation, community health workers, individuals who are
from and of the communities that we're trying to serve, who are trusted advisors already. And we have models of that show success, not only in terms of improving access to care, but improving patient satisfaction and improving access to clinical trials. And so I think that navigation needs to be expanded upon. We definitely need to find ways for payors to really be a part of that equation, and also find ways for us to make sure that there are ways for reimbursing for the time that navigators are part of the care team. And that's really a policy implication.
So I'll just briefly add on telehealth. I completely agree with all of my colleagues. And I think we need to learn how best to use telehealth. And I believe that has been very nicely addressed previously. I think we need to continue to bring the care closer to the patient, and Chris did a great job of talking about that. We all know that will facilitate healthcare, particularly for some of our marginalized patients. And I think we also need to focus on expanding the clinical team, making sure that everyone basically works at the top of their license, because it's not just the physician. It should not just be the physician. It should be a team. And I think that also helps with garnering trust from our patients. So there's a lot we can do with that.
And yeah, this is Dr. Christensen. Thank you so much. You guys brought up some very excellent points. Certainly, we learned during COVID that taking the care to the patient became a necessity as we were trying to keep people out of our facilities. And our community health representatives that work for our tribes are absolutely extraordinary. They are the ones who know where everyone lives, how to get to their home, how to get around all the roads that don't work anymore. And so I think that gives an opportunity to enhance what they do in our communities and to develop a more rule-based type care. I do also want to add, though, when you talk about working to the top of your license, we also have to look at non-traditional providers that we use a lot in our tribal communities, which is pharmacists and other aides, because they are invaluable. They ran a lot of our vaccination work, and we have to look at reimbursement for that because they are providing a very needed and excellent service to our people. So as we go along, we have to look at also how we're funding those who aren't our normal doctors, nurses, but who are invaluable in rural areas. So thank you.
And I'll just add quickly, I think what we did learn is that we can be innovative when we need to be. We can be collaborative when we need to be. And guess what? We actually can meet people at their point of need when we need to. So I think all of the innovations that were talked about, meeting people in their communities, really activating and respecting what navigations bring to the healthcare delivery process, the entire concept of really activating team-based care. We've been talking about this in healthcare for years, but our path forward is going to be one where we really activate team-based care in a way that involves the social worker, the nutritionist on the team, the physician, the psychologist on the team. Our path forward is one where we really understand how do we take a team-based approach in a community where people are, and not only address the medical needs, but be sensitive and understanding what COVID showed us, which is the impact of unaddressed social needs.
I want to reiterate what you just said, and that is, to be quite honest with you, many of these strategies, telehealth, that's not new. It wasn't COVID happened and we thought of telehealth. Telehealth was there. Yeah. We think about navigation. Navigation's been around since the 1970s and talking about bringing care closer to the communities. How do we better integrate with our community health centers? The wonderful part about, if there's any silver lining that COVID actually has, is this concept that it was a crisis that brought these wonderful ideas into action. And the reality is we're learning more, but many of these innovations were there. They were on a shelf, we didn't use them. Well, we use them in a very fragmented way. So the hope is that as we move forward, we'll tie these things together. I was going to give the next question to Randy.
Thanks, Rob. So Dr. Pierce told us that healthcare is a community enterprise, and Dr. Nunez-Smith said that communities are expert in what they need to thrive. Yet, cancer centers often have inadequate connection with and sustained presence in the communities and geographies. So the question is, we talked a little bit about navigation. Question is, what are some of the possible optimal models of community engagement that all programs should have? What are the essential elements? What does it take to provide culturally effective care How should we measure effectiveness? How should we maintain or sustain presence in the community? And how do we make our cancer centers accessible to all, as Dr. Lathan mentioned that we need to do, and what assets are needed to do all of this? So it's a big question, but community engagement is pretty important. So who wants to start?
I'll start. So I'll start with
Thank
nothing for the community without the community. So I think we have to be very intentional around how do we really begin to reach out and engage the community? How do we invite the community into the decision-making process? Not where they are just invited to the table, but their seat at the table actually has one of influence and power. How do we really begin to appreciate and respect what community-based organizations, whether they're lay navigator programs or other community-based organizations, have really been doing for years? And how do we learn from them? Because we're making the assumption that the solutions and the answers are not there. It's not that they're not there, it's that we have not created and engaged in a way for sustainable and meaningful change. Now's a great time for us to do that. So I come back to, let's create space and bring our community-based organizations in to the decision-making process and give them equal influence in terms of what really happens within the context of the community.
Yes, Ms. Chambers, you're like speaking my language. And I think a lot of times centers will do these things as a checkbox, right? You might have a community advisory board that's just kind of slapped together or thrown together without being thoughtful about who is it that you need on that community advisory board and how are you going to leverage their expertise and elevate their status, right? So we talk about this all the time, you know, in the context of comprehensive cancer centers where, you know, who is it that you have at the table, right? And I think, again, it becomes a checkbox for some of these institutions. And this is an opportunity for the NCI to really be a little bit bold in the way that they actually utilize the comprehensive cancer center model to really drive this real bi-directional communication and to elevate the status of community members. And I think until we actually start to do that, we're going to continue to have the same issues. Dr. Nunez-Smith brought up a really big point of making sure that we understand what the assets are in the community. And so we as institutions have to do a community assessment. And oftentimes that's just a look at big data. That is not it. And we have to be more intentional about how we do these community assessments to understand what assets are truly there in the community and leverage those to help support the community engagement strategies, but more importantly, the outcomes.
Dr. Wingfield, you said there's an opportunity. How do we make that opportunity mandatory? How do we create teeth to make it so that all programs need to do this? We don't need to rediscover this. We don't need to see the opportunity anymore. You started off with the NCI. What exactly should they do? Should someone else be involved? Should the Commission on Cancer? Should it be a requirement for accreditation? How do we turn this from an opportunity to something that is no longer optional? This has to happen.
It does. And I don't want to hog the time. We've got amazing experts on here. And so certainly I feel like, you know, if the government is going to be handing over millions of dollars to comprehensive cancer centers, there can be some teeth that apply to that. Now they're starting to move in that direction, right? Community outreach and engagement now being a section. But I tell you, comprehensive cancer centers know how to write. We know how to write. We really do. So part of it is figuring out what metrics we want to tie to that and how then do we utilize those metrics to actually move the needle forward.
I was thinking that I'd like to hear from Dr. Pierce and Dr. Segar on that as well. Segar on that. How do you move this forward?
So I think for one, you know, from our perspective, you know, a lot of care is also provided in the community setting. You know, community oncologists are key here. So increasing awareness of the challenges that they're facing, you know, understanding their data to see, you know, what's happening in their own data. There's a lot of areas where we find, you know, we did a lot of analysis with Cigna payer-based data using our claims to see what areas are the hotspot areas and then trying to focus and engage our community oncologists in those markets as well. And then making sure that they understand what's going on and raising the awareness. I was just talking to a group of oncologists here in my community here in Houston. They were like, yeah, we're aware of the problem, but what do we do once we are aware of the problem? We don't know what to do. So I think connecting them with the right resources, giving them information on how do you fix your workflow? How can you screen your patients when they come into your clinic on what challenges they're facing? So it's not enough if we just address this in the NCI cancer centers. I think it needs to be broader than that. I agree with all the speakers. I agree with what Karen just said, but I think the information needs to be widespread, and we need to get this out to the communities. And I think just from our perspective, we also look at screening rates, for example. I know we talked about screening earlier. Black communities don't always get screened at the same rates that others do. We identified a challenge in Memphis, for example, and our teams worked very closely with the community centers there, with the hospitals there in the area, to ensure that customers are engaged, that they get notification, not just from a payer, there's that trust issue that we talked about, but from their own community organizers closely that live and work in their own community. And we actually nicely showed an increase in screening rates. So it's possible. Access to care is key. We can all make a change, but I think it's being aware of what's happening and rewarding the physicians for the right workflows.
Dr. Pearson, Dr. Latham.
So I'll speak on behalf of myself and not for ASCO. I'm not wearing my ASCO hat on this. I think it's very important that we have this serious conversation and we bring the constituents together. And I agree with all of the speakers. Now is the time to do this. And we show where this works. We can show, as Dr. Oyer knows very well, Dr. Guerra's data that was presented at ASCO, where she showed that they doubled the participation of African Americans in clinical trials. She did a 5-year prospective experience and showed that when you bring the community into the discussion, when you have marketing strategies that are appealing to the community, that when you have the partnerships with the community, that you have the advisory board that was a meaningful advisory board, to Dr. Winkfield's point, she's spot on. And that there was transportation that was arranged. When you do this, you move the needle. When you look at the Delaware project that I spoke about briefly, the Delaware screening program, where you have navigators that work in the community and you have clinicians working with politicians, working with public health, working with navigators, you increase the screening, you increase the treatment. And for those who can't pay, you pay for them, the state, and you save money by doing that. These models work. And I think by bringing all the constituents together for a serious conversation and showing these things work and saying, now is the time to move forward, that's how we'll make this happen.
Yeah, that's fantastic. And one of the great things about being on this panel is all of these folks have done incredible work here. So where you hear us in agreement. I just want to say one thing, I'm push a little bit on the real talk on this. So look, right, you heard these things, intentionality, durability, bidirectionality, right? But when this question about why are we pushing on the cancer center so much, and what about the community providers? So here's the truth: like, the community providers don't have a lot of money. So if COC wants to come in and give an unfunded mandate about stuff you want to do, that's great. And many of us have been in these communities, and they'll say you need to do all this. With what money? They don't have the community benefits, money that we have. The places I've been, the community benefits person sometimes is the marketing person who's also the education person, and they're there for a year and then they're gone. So I think what we need to do is what Dr. Pierce talked about, especially when we're thinking about individual communities, and we're not even talking about specific cultural enclaves. We need to have policy levers as well as leadership from the cancer centers with collaboration with their community partners, because that sort of infrastructure work, you can't just go to a community and say, let's teach you what you should do, how you can get out there. By the way, you have 25 patients, you're seeing them in 20 minutes, go. I think we have to be really real about that and think about the policy levers that we can pull to make it happen.
So that leads me to, how do we manage the potentially competing interest of cancer centers investing in their community engagement efforts while also having to meet the business objectives of the cancer centers? For example, the payer mix. I mean, this is a real discussion. Want to get real? Somebody hit me up. Let's talk about that.
All right, I'm not scared. I'm gonna go again, because I think this is what I have said. What I would say here is, all we want is the same conversation that's happening in the business arm of the institution to be transparent. I think if you talk about, there are areas where the margin is better, right? Okay, so you take that margin, you fund your clinical infrastructure, but then there are some areas that will allow you to give a little more space to this other side. Nobody is, I think these are all nonprofits, and the large cancer centers generally are doing pretty well for nonprofits. And I'm not saying that they shouldn't have any margin. We're just saying that we just need to redirect that a little bit. The other last thing on this is I would say that this conversation is not particularly honest, because think about what we do for the research infrastructure. We will put in millions of dollars for an idea that might or might not work. And then we give it time and then we move along. But in this, it's a drop in the bucket comparatively. When we look at our community, ask, oh, I don't have any space or time for a navigator or a community educator. I don't really have any in the budget. You just put a whole center in for experimental whatever that might not bear fruit for another few years. I'm just saying that there's an opportunity here for us to think about this differently. That's all. I'm sorry if I got a little hot, but that's just how I feel about it.
Yeah, man, I appreciate that. And others?
Yeah, Dr. Wynn, this is a question I would have been asking you, because you actually are demonstrating how to do this, right? As a comprehensive cancer center at VCU Massey. So again, it's about where do you want to actually put the time and attention? To Dr. Lathan's point, institutions will bleed money whenever they think it's vital to do that. But here's the other thing, and this is where the policy piece comes in. If we as institutions are really clear and really want to make a difference in communities, this is where we'll go to our legislators and demand that we actually have some legislation that's going to provide support for the things that we know work. To your point, we can go back and look at unequal burden, these documents that have been produced by the Institutes of Medicine, been sitting around for over 20 years. Nothing that we're talking about is new. But you see what COVID did, it all of a sudden allowed for telehealth to be monetized, right? Or at least to be supported. It's not even like we're making money off of these things. It's providing an opportunity for centers who want to give good care to patients to be able to do it in a different way. And so this is where the policy piece comes in. So it's not just I hear you. I mean, this has to be, everyone has to be the payors. It needs to be the legislature that says we value everyone's lives equitably. And that means people in rural communities. That means the people who are of the underserved communities, Black, white, LGBTQ, whatever it is, that they are going to provide the supports that are really needed and we know work.
All hands on deck. This is the time. All hands on deck. And this is the positive side of COVID. We now know, I don't care where you are, this is the time to be bold.
Bob, do you mind if we switch gears a bit?
Yes, sir.
We're running out of time. I'd like to, I think we have some structure, some idea where to go here. So next question is structural inequities, structural barriers, racism, and bias all cause injustice in cancer care, delivery, and health outcomes. What steps must be taken by departments and institutions to undo systematic exclusion? What plans must be outlined? How must these be measured, integrated, and corrected? Dr. Wingfield, you mentioned departments. You also mentioned individuals stepping up. But what do we need to do? What do we need to actually make standard in our care?
Yeah, so it's a great point. And I, again, would turn people back to the paper that we wrote. There's a lot of work that needs to be done. A lot of the issues, I mean, people say, well, I'm not racist. We're not saying people are racist, but there's a racist system. And we've got to acknowledge that and to see how the system has really worked against people. Just take redlining, for example. And we know that redlining has been happening since the 1930s, around housing, but literally redlining has created segregated communities that are unable to build wealth, and wealth equals health. So there are things that all of us have benefited from racism in one way or another, structural racism. So you have to learn what those barriers may continue to be so that we can break them down. But the other thing that I must say from an institutional perspective, if you are a cancer center and you're not accepting Medicaid patients, that's a problem. Right there, you're telling a whole group of people that you don't care about them because they're poor. That has to change. And this is where legislation comes in. I mean, if you're getting money from the government for other things, for research or other things like that, the government can simply say, if you are getting funds from the National Cancer Institute or NIH, you must accept Medicaid. and you must take care of patients, and then make the institutions figure it out.
Others want to chime in on that?
I mean, she really, it's the reason you hear quiet is because I think there's just complete agreement with what Karen just said, right? I think this is something that should be non-negotiable for, cancer centers that are, getting grant funding. I think that should be non-negotiable. And then there should be help for those community partners that are struggling, because there are some smaller places. There are, even if, that are really trying to do all of these things, they lack any of the structural supports and all this other infrastructure. And I think if we really need to think about how we want to do that, and yes, there's policy issues, look about the states that didn't expand ACA and all these other things. There's great data here that shows us that this matters. But I think, what Karen said is perfect. We just need to make sure, pull the policy levers to make it work for the most vulnerable among us. And that's how you're going to see it. I mean, we need to be as intentional and innovative in this area as we are in our science, where we are doing great work. That's,
But Lori, but when it comes to, say, rural and Indian Health Services, how does that work? Because that seems to always be a significant challenge.
Well, it is indeed. And, we actually we support all our Indian Health Service patients. We do have funds that we can get them to cancer centers and treatment. But we're a small population. So when you look at us as a payer, you're not so compelled to reach out and spend extra resources and take the time to come out to a very rural area, as Karen was saying, to actually establish a relationship. There's a lot of issues that have to be taken care of. And we have 574 tribes, each with their own nuance. But that first thing is community trust. And you can't do that in your granite buildings of cancer centers. You have to do that out in the rural areas and become part of those communities. Our most successful programs are when they integrate people into our communities, like Johns Hopkins, the COPE. They live here with us. They're trusted leaders in our communities. And therefore, we do engage in clinical research. We are becoming more interested in being part of these studies. And that is all very, very key to us. And we're here. And we can certainly meet you and teach you and help you be culturally appropriate and knowledgeable about how you're treating our American Indians and Alaska Natives. And we look forward to those partnerships.
And if I can just add something really quickly, I really want to underscore something that Dr. Winkfield mentioned. And when we talk about structure, Dr. Kamara Jones often talks in one of her analogies about open close. And so when we begin to convey messages that say contingent upon your insurance type or your social economic status, we're conveying an open and closed message to individuals before they even step on the grounds of our institution. And so by not saying a word, when we're not accepting individuals who are Medicaid, or it's when we're not accepting individuals who are uninsured, we're saying to them that our facility is closed to you. You are not welcomed here. So in our nonverbal, we are really communicating a very loud message. And when we do that, it doesn't just hit that person, that patient or that family. It impacts that entire community, because you end up ostracizing an entire community with your nonverbal structural messages of I am closed to you because you don't meet the quota, you don't meet the status quo, you don't look like, feel like, have the economic integrity or the economic resources that we need in order for you to be able to cross the threshold of our institution. So we should not be offended, upset when individuals don't respond to us, because we've been saying for years to them that we are closed. And so what they're saying to us is that we're not closed to you.
Got that. I like that. I know we're running up against time. I'm going to put in one, Dr. Ware, if you don't mind, I'm going to try to sneak in one quick question. We talk about social determinants of health all the time. Well, what's a social determinant to health that you guys are either collecting? What type of data? And how are you actually doing more than collecting? How are you actually making that real, collecting and then acting? Just anybody will take that. I know it's real short answer. That's another discussion for another time, but I want somebody to address that. What social determinants, how you taking the information, not just collecting, but doing more than collecting with the social determinants that you get?
Yeah, so when one of the last supplements that we got for our CCSG, this is before I left Wake Forest, for our P30 grant. We actually wrote a proposal to actually bring financial navigation into the Comprehensive Cancer Center. And that's different from having a financial manager, right? Having someone who's just trying to kind of collect the dollars from patients. This is someone who can actually do a broad sweep of what people are facing in terms of things that are going on at home and around and in their community. So we actually pulled in several kind of measurements tools around social determinants of health. But it brings up another point though, like who's gonna do this? Who's gonna collect the data? You know, we all collect zip code, and that's one kind of way to think about social determinants of health, but it's just one. The more difficult and challenging thing, this is why, and I'm not saying we need to pull our community partners in, but those of us who are getting research dollars need to think about how to do this whole social determinants of health thing better. Like, how do you measure community support systems? You know, how do you measure comfort level? You know, how do you measure discrimination well? These are all things that are part of the social determinants of health. So it's not just looking at social issues, right? Or context that will help them get to and from a center, transportation being one of them. But those are just basic things. And I do think, and one of the things that I've really encouraged my colleagues at every cancer center I'm doing is to really have someone, whether it be a nurse, it can be one of the MAs as people come in, ask them, is there any issues that are going to prevent you from getting to and from your cancer treatment? Just starting with that. It doesn't have to be anything major. And then they can jot that down and the provider can come and have a conversation around that.
Dr. Wingfield, that was, go ahead, Dr. Pierce.
To follow up, Dr. Wingfield, we need to know how to ask the right questions to solicit the social determinants of health. At ASCO, we have a podcast series, a social determinants of health series. And one of the series was, how do you take a social determinants of health history? You know, we as physicians have been taught how to do H&Ps. We don't necessarily know how to ask the right questions. And that particular episode was one of the best episodes about how you take a social determinants of history. You listen, you ask the right questions, you partner with your patient. And I think as physicians, in addition to the other members of the team, as physicians, we need to learn how to take a social determinants of health history. That's where it starts.
Well, thank you very much. I think Dr. Oria and I would agree that this has been a robust discussion and a very great panel. I really appreciate you all and want to thank all the speakers. We'll have a 15-minute break. It'll probably be a 14-minute break. We're going to start session 5 about learning rapidly to improve the conduct of cancer clinical research beyond the COVID-19 pandemic, and that'll start at 12:50 p.m. Eastern Standard Time. But again, I just want to say I appreciate you, and this is the beginning of something good. So thank you all.